Good morning, everyone. One of the best things about all of us coming together is the fellowship. So it's actually kind of sad when we have to flash the lights or stop the talking, because it's great for there to be a time for everyone to come together and get to network and talk and just take time out of the day to fellowship, because most of you work in different roles in different hospitals, healthcare systems, social service agencies, and sometimes those days are rough. So having a moment, having a break is a nice opportunity. So welcome to the University of St. Francis. My name is Amelia Clark. I am the Executive Director of the Center for Integrated Public Health Education and Research. That is a really long name, so we just call it CIPHER. And we have been partnering with the St. Joseph Community Health Foundation to host the PIC luncheons here on campus. And I think this is a record number since we have started doing that over the past year. And I'm really pleased to see that, because today's topic is a really important topic that we've seen in our community health needs assessments. And we've got a really great lineup of speakers. One of the things that the university is currently working on is being able to offer continuing medical education for physicians, nurse practitioners, and physician assistants who attend these luncheons. So I do need to share with you an accreditation statement, a designation statement, a disclosure statement, and policy that no one today is receiving any type of financial remuneration or any type of, there's no type of device or financial kickback that they will receive for any type of medical device or anything from their presentation today. Unfortunately, we are still in that process, so I cannot offer CMEs today. However, I can, if you are in need of continuing education credit or continuing education units, like you're a social worker, an RN, a case manager, I can do that for you. And at the end of the presentation, if you scan the QR code and fill out the survey, we can give you an hour of credit for today. And I can take care of that. If you do the QR code, and Sabra, she's waving back there, I'll be sitting next to her. If you just stop by and see us and sign the sheet, we will make sure you get a certificate with your hour of credit. And Meg, right there.
Hi everybody, I'm Meg Disler. I'm the Executive Director of the St. Joe Community Health Foundation. We're a small local foundation here focused on helping some of the more vulnerable members in our community access health and wellness care. And we have a special dedication to really helping women and children flourish in our community. So we've been doing these prenatal and infant care PIC luncheons. I looked it up for 9 years. And we are really grateful for the support that we've been getting with the University of St. Francis to open up their home for us as well. These are recorded so that if there is a great piece of knowledge of information or you want to get a PowerPoint, all that will be up on our website. Usually takes us a couple weeks, but you can also reach out. If you look on our website, you can find all of our contact info if you need something sooner, but we'll be getting it back to you so you can share an important fact with any of your colleagues or clients or anybody that you want to make sure you get an accurate reference to. One of the things that we love to do is make sure we know all the wonderful resources in our community. A piece of that is we want everybody to very quickly introduce themselves and your agency, and if you have a 10-second commercial like, I've got room for these women who need this, let me know, or we have extra resources in this area, or we're looking for help in this, feel free to say it, because we have found that the networking in here has really helped people connect not only their clients, but their services when you're run out of service or something, or so we work as a community. So I'm going to ask you to just very loudly say this. We don't have a mic. Stand up, say your name, your agency, and pass it on if you need to the next person. Please start.
I'm Kelsey. I am a women's and children nurse navigator at Adams in Decatur, and I'm really here just to learn about the information provided. So.
Hi, I'm Kathy Thornton with the Health Department. I'm Director for HIV and STD Prevention. If somebody needs some testing and treatment, that's what we do.
Hi, I'm Erica Pitcher. I also work for the Health Department. I'm the Director of Clinical Services and Infectious Disease Case Management. Same offerings as Kathy. Lots of testing. If we have any parents, pregnant moms with infectious diseases, we can help them. We also have a needle exchange. If we have pregnant moms who are currently using substances, we can help them as well. So.
Good afternoon, I'm Matt LeBlanc. I'm the Communications Director at the Allen County Department of Health. If you'd like any information about programs and services that we offer, or to get in touch with anybody here, feel free to contact me and touch base with you later, and I can get you some contact info.
I'm Kristen Merriam. I'm also with the Department of Health. I'm our new health educator. So if you need anybody to come speak to you or provide materials on anything, we can probably get that done. Vice versa, if you need questions or anything, want us to come speak to people for you, contact me.
I'm Darlene. I'm also from the Department of Health. Erica was talking about the SERN program. I'm part of that, and I do harm reduction. So I also work with like Hep C cases and the overdose fatality review.
Hello, my name is Ruth Reynes, and I work at Catholic Charity. And I and my two co-workers here do what we call pregnancy and parenting case management, and ECHO, which stands for Education Creates Hope and Opportunity. So somewhere in here is probably a Lutheran social service person that does ECHO. Oh, okay. All right. So we kind of share Allen County and the surrounding counties, and we try to help young ladies who've gotten pregnant in high school and overcome the barriers that would keep them from graduating and then going on to some other further education. But we take any woman, no matter what their educational level or age, that's kind of in crisis and wants case management and has a child under age 1 or who is pregnant.
Like my lovely coworker Ruth here said, Caroline Bradford from Catholic Charities and Community Services Case Manager.
Patricia Williams, case manager at Catholic Charities, Community Services.
Mary Millis, I work for Bright Point Head Start as a home visitor. We do home visits each week in the home for prenatal moms up to age 3. So if you know anybody that needs a home visitor, let us know.
I'm TC Spellman with the YWCA. I'm an education coordinator, and so what I'll talk about is that we offer free community education as well. Our topics are about domestic violence and addiction. We also have 8 programs. We have a 6-county service area, so anybody who might be interested in that for their clients or for their staff, come see me. It's free and it's fun.
Kenny Thomas, I run the Fatherhood Department for Healthier Moms and Babies.
Nicole Fairchild, I'm CEO at McMillen Health, and you can learn all about us during the presentation today.
You know me already.
We'll start back. Yes,
I'm Belinda Dean, social worker with the Neighborhood Health Clinic.
I'm Angie Phillips. I'm the Early Prevention Services Manager at Lutheran Social Services, and I oversee our ECHO program, Year Up, and Christmas Days Off program.
I'm Ashley Buckinson, and I provide counseling services to moms through a program called Journey Beside Mothers through Associated Churches.
And I'm Julie Von Gutten, and I am also with Associated Churches, Journey Beside Mothers. We offer mentor friends that we pair with moms,
We also have evening events twice a month for education and fun for moms. And we also have a weekly play group on Wednesdays for moms of preschoolers.
I'm Hannah Cottingham. I work for Hope's Harbor. I'm the development manager there. We are a respite home for families with hospitalized children. So it's completely free for our families. Lots of NICU, PICU, peds, moms, and dads, of course.
I'm Britte Strom. I'm a family case manager with the Department of Child Services. And you all know I am Misty Caldwell. I'm a family case manager for the Department of Child Services as well.
My name is Renee Cleland. I'm a birth doula. I take private clients, and I also contract with Healthier Moms and Babies. Healthier Moms and Babies has an excellent doula program. If you know any moms who could benefit from the support of a doula at their birth, walking alongside them during pregnancy and then at their labor, and then postpartum in-home visits also, they can contact Healthier Moms and Babies for more information, and that's free of charge.
I'm Rachel Gilson. I'm the undergraduate nursing clinical director here at St. Francis. Prior to that, I taught maternity here for 7 years, and prior to that, I did L&D at Lutheran Birthplace for 7 years. I don't really have much to offer you, but if you want nursing students to come do observations or you think it might be a good opportunity, feel free to reach out and I could help coordinate that.
I'm Ann Keel from the Women's Care Center. I'm director of the 3 centers in Fort Wayne, and we offer free pregnancy testing, ultrasounds. We have Medicaid enrollment thanks to Brightpoint twice a week, and we have just started first prenatal visit at this center. So we're happy to help.
I'm Jennifer Richard, full-time nursing faculty here at USF.
I'm Beth Minnick, and I'm also at Women's Care Center. I'm a social worker, counselor, and parent educator. And we also just started ESL classes.
I am Tasha Davis. I'm the founder at Young Mothers of America, and we offer support to at-risk, underserved mothers, fathers, and children, and we do a whole lot. I also am with Women's Care Center.
Hi, I'm Dana Wyatt. I am the perinatal bereavement coordinator for Lutheran Health Network. I'm also the founder for Walk to Remember Incorporated, and we provide a remembrance walk every October.
Stephanie Good, I'm the birth navigator at DuPont Hospital. We provide free childbirth education to families wanting to know a little bit more about their pregnancy, birth. I also just received about a week and a half, 2 weeks ago, a permanent fitting station for car seats.
Cassie Minnick, family case manager at DCS.
I'm Rachel Herb. I'm the family case manager at DCS.
Christiane Soltz. I'm a nurse by training, always been maternal child, and a women and children's health specialist with Care Source of Indiana. We're one of the nonprofit Medicaid companies that services visual health-wise. So I think the biggest thing is just remembering that your patients you're taking care of that have Medicaid, get them back to their Medicaid company because we do have wraparound services.
Hello, I'm Yasmin Flores. I'm a community health worker at Parkview. We provide education for women that are pregnant up until the age of their children turn a year old. So we pretty much do a lot of prenatal education. We also connect them with different resources.
Hello, I'm Taylor. I'm a cessation coordinator with Tobacco Free Allen County, and I work with employers, community-based organizations, and healthcare providers to address tobacco use with their employees, patients, and clients.
Hello everyone, my name is Godwin Haruna. I work in the US there as an instructional designer. I'm also a health enthusiast. I like health research as well.
Hello, my name is Maria Martinez, and I work for Healthier Moms and Babies, family advocate, and we do prenatal education.
Hello, my name is Natalie Rwamba. I'm the director of the Teaching and Learning Service here, and I'm just here to learn about the topic.
All right.
my name is Liz Andrews. I'm a social worker with Parkview, and our team works with women struggling with addiction during pregnancy and a year out.
I'm Kathy Netweiler. I'm support nurse navigators, community health workers, and FIMR coordinators at Parkview.
I'm Erica Deathe. I work with Liz, and I'm a maternal recovery specialist at Parkview, working with moms during pregnancy and postpartum who struggle with substance use disorder.
I'm Megan Murray. I'm Erica's co-worker. I'm a maternal recovery specialist at Parkview.
Hi, I'm Brittany Fields. I'm with the Department of Children's Services here in Allen County.
Hi, I'm Celeste J. Luke. I'm with the Department of Child Services here in Allen County.
Sarah Muriel with Department of Child Services in Allen County as well.
Tamika Johnson. I'm a child advocate at the YWCA. I deal with anything child related.
I'm Sydney Wilson. I'm an intern at Parkview with the Women and Children's Department.
I'm Laura Pfluger. I'm a social worker with the Women and Children's Outreach Team. I'm located at the OBGYN office at First Street.
I'm Britte Nihart. I am supervisor of the Women and Children's Nurse Navigators at Parkview and FIMR coordinator for Allen County.
My name is Abby Gavitt, and I am also a social worker with the OB department. I support the North and Southwest locations.
I'm Brittany Wessel. I am an OB nurse navigator. I service mainly the DeKalb OB office and the Huntington and Wabash offices.
I am Sarah, OB nurse navigator in Allen County.
Good morning, everyone. I am Dominique, and I work at a Hope Center. I am the charge nurse for the South Clinton location, as well as a sexual risk avoidance specialist.
I'm Teresa Bauer. I'm a staff nurse at a Hope Center, South Clinton, as well.
I'm Emma Yaniga. I'm the Echo Case Manager at Lutheran Social Services.
I'm Colleen Harlan. I'm a nurse manager for the Columbia City and the South Clinton locations there.
I'm Leanne. I am the Director of Medical Services for Hope Center. We have 3 locations, Columbia City, South Clinton, and Hobson. We offer pregnancy testing, STI testing, and ultrasounds, as well as an education program for parents.
I'm Natasha Richardson, and I am a nurse home visitor with Healthier Moms and Babies.
I'm Tara Stoops. I'm also a nurse home visitor with Healthier Moms and Babies.
I'm a little trapped. I'm Rochelle Hirschberger, family advocate with Healthier Moms and Babies. If you didn't notice, we have fatherhood and doula and nurses and family advocates. We also have mental health that can support any mom at any stage, because we know momhood is hard in lots of different points. I was also going to say family advocates are expanding, so we can see our clients more often and for longer now.
And I'm Esther. I'm with Healthier Moms and Baby as well, and I'm the Burmese family advocate, and I have about 47 Burmese moms under my case, and then they are all ready to pop. So.
Oh, that's wonderful. I have to just say that I always am filled with hope when I look at all the resources, the talented women with huge hearts and the talented men in this room who are committed to helping women and children flourish in our community. I would be remiss if I did not thank my team, who I get to stand up here in front, but they're the ones who make it all happen in our office, pulling it together. Mark Burkholder is the gentleman in the blue sweater back there who helps with all the multimedia, helping us to the event coordination. Mary Tyndall, who also helps us in our office with food and nutrition and a lot of our storytelling. And I did Marla and Chuck Dewey was Marla Russ, who needed to go back to Matt and run the things in the office. We'll be introducing Sarah in a few moments. I like that we have a couple of different people. You have the agenda in front of you, so I want to move quickly to Britte Nihart. Britte is not only a registered nurse, she heads up women's and children's nurse navigation with Parkview Health. but we particularly asked her in this setting as the coordinator for the Fetal Infant Mortality Review Group, which has the tough task of looking at all the poor outcomes, the deaths of county infants. What happened? How do we prevent it? And so she's going to give us a little update what FIMR is seeing relative to this. So, and while I'm saying that, she has had over 20 years experience working in maternal child health. And how many mothers do you think you've impacted?
I have tried to put a number to that, and I honestly can't, because I've worked at different times in my life, full-time, part-time, you know, various schedules. It's in the thousands. I'm sure it's in the thousands. I started in OB in 1997, and I've been mostly in OB ever since, in some form or fashion. So.
So we have a lot of expertise, so we'll just keep asking that question of each of them and try to stump them if they know. Thank you.
Thank you. So yeah, as Meg said, FIMR for Allen County, we do just what she said. We review all the fetal and infant deaths from residents of Allen County. And so we're usually a year or so behind from the time it actually happens before we review them. We try to look at all the records we have available, so medical records, prenatal records, if applicable, as well as you know, if there are police records and things like that, DCS, depending on the situation. Allen County also has a child fatality review that does some of those if they're coroner's cases and things like that. But when I was asked to talk about this, how marijuana has been affecting pregnancies in our county, I pulled a few numbers. It's kind of hard, and I'll explain why, to get good data. In 2022 cases, we reviewed 33 in Allen County, and 8 of the 33 we know for sure the mother used marijuana at some point during pregnancy. 4 are completely unknown. We have no idea because we don't know that anyone ever asked her, and she was never tested, never had a urine drug test. And then 21 said they didn't, and either didn't have a urine drug test, so we took them for their word, or they said they didn't and they had a clean drug test. So that's kind of why it's hard. The drug testing and screening is very, it's not standard. It's kind of all over the place. It's very dependent on the provider you go to. So out of the 5 that as of January, we had reviewed 5 from 2023 so far, and 3 out of those 5 were for sure positive on marijuana. Out of all of the ones that we reviewed that we knew had used marijuana during pregnancy, the average gestational age at the time of the baby's death was 26 weeks, and only 2 made it to the 9th month of pregnancy, and both of those had some type of chromosomal or malformations related. So it's hard to know if that's related or not to the drug use. There's kind of no way of really knowing, but it's just what we've seen. Women are sometimes afraid to admit to use when they come for prenatal care for various reasons, but there's a stigma. They don't want to be judged or to feel like they're being judged by the healthcare team. And there's also a fear, is DCS going to come and take my baby away because I admit that I've used. And as I said, there's not a consistent rule or law or you know, even guidance, I don't think, for OBs or midwives to test or to not test for drug use. So that makes it difficult. Sometimes I know patients are tested and they're not told they were tested, and then so if something comes back positive, the provider needs to address that with her, and that can be an uncomfortable conversation. I mean, it's always uncomfortable, but if she didn't even know she was tested, it's going to be really uncomfortable. And providers don't, even if she knew she was tested, providers don't really know how to talk to women about this. this is not their wheelhouse. These are OBs or certified nurse midwives, and substance use and mental health is not their specialty. So it's really a difficult thing, and sometimes, honestly, it just doesn't get addressed. Or the provider might say, you know, your urine drug screen showed that you were positive for marijuana, you need to stop. And then they just move on to the next thing. So there's definitely some needs here in this area. Reasons that women say that they use, if they're asked, it's often thought of more and more so now as a natural option. It's better in their minds than taking a medication, a prescription medication that comes with risks, because it's natural and it's legal in Michigan, it's legal in Ohio now, you know, so therefore it must be safe. They'll say, well, my sister or my best friend or my cousin, they smoked throughout all of their pregnancies, their kids are great, healthy. They just don't believe that there's any risk in it or any harm. They will say that they use it for their appetite at the beginning of pregnancy because they're nauseous and they can't eat, and so when they smoke it or use it in whatever form, it helps to increase their appetite, which they feel is better for the baby. They also will say that they have increased anxiety levels during pregnancy because of pregnancy and all the changes happening in their lives, and so they need it to calm their anxiety. So those are kind of the most common reasons that we've seen that patients say they use it. There was a study that I found, a 2015 study of 90,000 women that showed that 70% of women, pregnant or not pregnant, believe that there's a very slight to no risk of harm in using marijuana 1 to 2 times a week during pregnancy. So that's a large majority of people feel it's safe. So, you know, why does it matter? Why do we care about this? I'm going to just skim through a few of the risks. I'm sure other people are going to be talking about that, but there is a higher risk of preterm birth, stillbirth, small for gestation, so the baby is weighing less than it should for the gestational age of the pregnancy, and a 12 times greater risk of SIDS deaths if mom has smoked marijuana during the pregnancy. In the child fatality review cases, we review the sudden unexpected infant death cases in Allen County, and frequently they do find evidence in the home that marijuana was being used, and sometimes the parents will admit to it, mom or dad, that before they went to bed that night they were smoking. Is it directly causation? You know, were they sleeping deeper? Were they sleeping more soundly and they just didn't realize they rolled over on the baby? That kind of thing. It's hard to say, but it definitely seems to be correlated for sure. And recently, in Allen County, we've had some cases of pregnant women using marijuana and then finding that they go down. It was laced with fentanyl, so they end up, you know, someone Narcans them and it brings them out of it. But in this day and age and in this community, that's a huge concern. So women might think they're doing something safe and natural, but I mean, one use of something that's laced and they can die. So
thank you for sharing. It's always tough to hear this, but it also, we can learn so much. So thank you, you and the whole team you've got in review. It's a great volunteer effort in your community, so thank you. Now I'm very pleased to introduce Dr. Sarah Turner. Sarah is a family practice physician in this community with the Lutheran Health Network. She's been doing that for 12 years and practicing family practice at Lutheran in this community. And so, I know, I like the colors. What do you think? Or channeling spring. You've also run the Monarch Clinic for years and really has spoken to this group at least once or twice before. but is really one of the great experts in this community. So with that, I'm going to turn it over and let you share.
Is this? But this will do it remotely. Maybe?
You're up on the screen up there.
Okay. Hi, I'm Sarah Turner. I'm family practice trained. I did a 2-year fellowship in maternal, child, and reproductive health. And that's where I got my first exposure to women who are using substances in pregnancy. I was terrified to start working with this group because I didn't know anything about it, and I was worried about how I was going to connect with them. And I absolutely fell in love with that kind of work. And so my goal was to come back and start a clinic that was modeled after the one that I worked at in New Mexico. And that's my Monarch clinic. Monarch stands for Maternal Obstetrics, Newborn Care, Addiction Recovery, and Reproductive Health. So, or comprehensive health rather. So my goal is to be able to be a wraparound clinic where they can come for their primary care, OB, peds, psych, substance abuse, all the stuff. So I love what I do, and I could not do it without this community. And it's so awesome seeing this group getting bigger every year and seeing the same faces and same names. So thank you all for being here. So I'm going to talk to you about marijuana use in pregnancy and lactation, and I have to say, I learned so much just in researching this because there's so much that's new. Like every day we're coming out with new research, and a lot of this stuff wasn't even known when I was in medical school. So a lot of the stuff I'm going to teach you, I'm going to give you a big science lesson today, which is super fun. But in putting this presentation together, I'm absolutely going to be changing how I practice. It was really interesting learning a lot of this stuff. I obviously knew it wasn't good, but I didn't realize how bad it can be and some of the risks associated. So disclosures, I was a medical consultant for Pfizer. I'm not anymore. But, so we're talking about marijuana today. It's got a lot of different names that it's known by. Cannabis, blunts, pot, Mary Jane. There's lots of different names depending on where you are. My nurse practitioner, when I was practicing with her yesterday, she was like, broccoli, I heard it in a rap song. Broccoli. So it's marijuana is what we're talking about. Marijuana, if we remember back to science class, we have the kingdom of Plantae. We're down all the way down here in the family Cannabinaceae, the genus of cannabis. And then at the very, very bottom, what we're talking about is the species of Cannabis sativa. That's where marijuana comes from, so it's right there. Fun fact, in the same genus is hops, beer, so I didn't know that. Cannabis versus marijuana versus hemp. So cannabis is the species, and marijuana and hemp actually both come from Cannabis sativa. They've got a lot of different differences. So when we're looking at THC, which is the psychoactive component, hemp has, by definition, it has to have less than 0.03%, whereas marijuana has greater than up to 30%. CBD, hemp has about 20%, and marijuana usually has less than 10%. Hemp is non-psychoactive, marijuana is. Hemp is legal federally, and then although legal in certain states, marijuana is illegal federally. Hemp is regulated by the FDA, and why that's important is that they have certain standards they have to follow in order to be safe for human consumption. Not the same for marijuana, it's enforced rather by the DEA. And we use hemp for things like hemp oil, CBD oil, textiles, rope, body care, construction, whereas marijuana is just for medicinal and recreational purposes. So, if we look at the components, CBD versus THC, looking really, really closely, they're almost identical, except this little double bond here is a single one here, and this little oxygen here isn't connected. And that's literally the only difference, but tiny differences can make a totally different component. So what do we use these and how do they work in the body? CBD has a lot of actual great benefits in ways that it can be used. It helps with anxiety, antipsychotic, anti-inflammatory. It can be used in certain cancers. In epilepsy, for pain, it improves sleep, it can help diabetes, and there are studies that are showing it can be used in treating cardiovascular disease, which I didn't know that. THC, we do use it a lot in certain areas. It can be an appetite stimulator, a relaxant, and we use it for analgesia. It does cause euphoria, and it can cause paranoia and anxiety. In people who are predisposed, it can trigger schizophrenia. And it's not causing schizophrenia, it's people who probably were going to get it at some point anyway, it can bring it out. So. And then looking at marijuana in pregnancy, so it's the second most common used substance in pregnancy after alcohol, not including tobacco. Self-reported rates are around 2 to 5%. That's probably grossly underestimating the number of people who are using, especially given how my office often smells on a day-to-day. 50 to 28% of these people who are using are young, urban, socioeconomically disadvantaged patients. And 34 to 60% of people who are using prior to pregnancy will continue to use. They're more likely as well to use tobacco and alcohol in pregnancy, so that's like an important point. And about 8% of people who try it will become dependent, and about 18.1% of pregnant patients who reported use in the past year actually met criteria for dependence, abuse, or both. So what are the perceptions? As Britte was saying, it's low risk to baby because it's harmless, my baby was fine, my neighbor's sister's cousin's, you know, person that they work with, their baby was also fine. It's natural, it's an herbal remedy, it's safer than prescription medicine, false. There's, you know, a lack of information coming from or communication with their providers. And so when people aren't talking about it and aren't asking about it, especially when they come into an office smelling like it, they think, well, it must be harmless, it must be safe. If they're not saying anything or screening, if they ask me about alcohol, they ask me about tobacco, they ask me about fentanyl, they didn't ask me about marijuana, it's probably safe. And in studies, they show that only 51% of patients were actually counseled on the risks in pregnancy, and only 4% were counseled on the risks of lactation. So we're definitely not doing our due diligence on the doctors. So who's continuing to use? And this is not everybody, there's definitely people outside of this, but risk factors for continued use are going to be younger women who are generally more likely to be single or unmarried, lower socioeconomic status, especially patients who are unemployed, lower education, especially patients who do not have a high school diploma, women who smoke, and then women who are underweight. And then if their partner uses cannabis of some sort, also that's a huge risk. And that's with any sort of substance. It's really hard to quit something when someone's using it right in front of you. So, perinatal depression is a big one because, as was already mentioned, people use this as self-treatment. So that's definitely one of the biggest risk factors I see in patients. Again, there's this perception that it's safe. It's an herb. Well, belladonna is an herb. It can kill you. So can death cap mushrooms. It's legal. Without getting political, there are definitely legal things that can hurt and kill you. It's natural. Well, what else is natural? Uranium is natural. Snake bites are natural. Pufferfish are natural. These things can all kill you. So just because it's natural doesn't mean anything. And why do people continue to use? So we get the recreational use, obviously, and then we have people who are justifying it, or they know it's bad, but they're self-treating conditions. Nausea and vomiting is the big one. Anxiety and depression are definitely big ones. Sleep disorders, I can't sleep without it, especially if they've been using it every day for 7, 8, 10 years. And then pain. I have patients, I've tried everything and this is definitely safer than opiates. I don't want to get hooked on opiates. So they might get bad advice from family and friends. They might get bad advice from practitioners. You would think that if you walked into a dispensary where they are dispensing medicine, medical marijuana, and someone tells you it's safe, you would think you could trust that, but that is one of the #1 places that people get told it's safe and do use this for nausea and vomiting. Then TikTok and Instagram, as much as I hate these, this is where people are, and we just need to start flooding it with good information. And here's a great example of how it could be used terribly. So the Jamaican study, this is one of a big study that a lot of people use to justify this. This was done in the summer of 1969 in rural Jamaica. So as man was landing on the moon and 40,000 people were gathering together at Woodstock, ironically related. Melanie Dreher, she was a RN and an anthropology student at Columbia University. She went to rural Jamaica to study how people use cannabis. The reason she chose this was because of the Rastafarian group. I'm not sure how familiar you are with Rastafarians, but in the Rastafarian religion, they smoke marijuana as a religious practice. It's the way of becoming closer to their God. But they're incredibly health conscious, and by their religion, they do not smoke, they do not drink, they don't eat meat, they have a raw vegan diet, so they're very health conscious otherwise. So it's an interesting population in terms of getting rid of a lot of the confounders that get in the way of a lot of these studies that we're doing, because we're just seeing marijuana in this group. So she studied men who were working in the fields who said that they felt like it was making them more efficient. They studied children where moms were giving it to them because they focused better after school. And then they studied a lot of pregnant women. She had a group, I think initially the group was about 59 women large, but she ended up following 24 babies who were exposed to marijuana and 20 who were not. The ones who were sort of varying in their degree of how much they were exposed to. They checked in at 1 and 3 and 30 days. And they did a evaluation on these. She didn't. The person who did it did an evaluation on these babies in terms of their physical and social sort of developmental things that they were showing. It was blinded, so the person who was evaluating them did not know who had been exposed and who had not, which is always important in our studies. And they found that at 1 and 3 days, no difference. These babies were all the same. Great. Okay. But at 30 days, the heavily exposed neonates were actually more socially responsive, more autonomically stable than their counterparts. The quality of their alertness was higher, their motor and autonomic systems were more robust, they were less irritable, and in general, they were judged to be more rewarding for their caregivers. So you might read the study and be like, oh my God, everybody needs a joint after they have a baby because, yeah, who needs it more than a pregnant mom, right? But, obviously they don't tell you everything. What did they not tell us in this study? Well, they didn't talk about how the women in the exposed group had a higher level of education. They had more financial freedom than all their counterparts. They had fewer children in the home, so they could spend more time with these babies, working on their development. And so when we're not getting information like this, it's easy to take studies, and this is one of my biggest preachy things that I do with my patients is, if you want information, please let me give you good information, because just because you read a study, oh, this study showed 80% of babies did that. Well, 80% could be 4 out of 5, or it could be like 400,000 out of 500,000. So just because you read a result doesn't mean you know necessarily how to interpret it. So I wasn't impressed. Limitations to the study on top of this, and there were good things about this study, but limitations to the study, they chose these women by having the midwives who they were going to screen them, and so there's possible bias. We're already at baseline picking women who are coming to prenatal care. It was a very small sample size. There was a little bit of power and there was a little bit of clinical significance, but overall, I wouldn't be making any judgments based on this. And you can't control the environmental and other confounders, so we're not controlling how much are these babies sleeping, are the moms smoking while they're breastfeeding, what are the moms eating, et cetera, et cetera. So not a great study. But going back to nausea and vomiting, this is 51% of women who use it in pregnancy. This is why, interestingly, there's a paradoxical link that women who smoked prior to pregnancy have more nausea in their pregnancy. And I don't know about any of you, but I never looked like that when I was nauseous. That's why I picked that picture. I Googled like stock photos, nausea in pregnancy. Makeup is just on point. But it's generally viewed as a safer treatment than pharmaceuticals since it's an herb, but we do randomized controlled trials on pharmaceuticals. We cannot do randomized controlled trials on marijuana. So when we talk about safety of Zofran, we have done studies, like massive, multiple studies on Zofran. And a lot of this stuff is recall studies, longitudinal studies. They're not studied well. We also have cannabis hyperemesis syndrome, which can show up in pregnancy a lot. I think our family practice residents admit someone at least once a year with this. So usually it's episodes of diffuse abdominal pain, nausea, vomiting. It's usually about 24 to 48 hours long. In pregnancy, they tend to get admitted to the hospital a lot more because at baseline, a lot of them are dehydrated and vomiting, and so they get admitted mostly for hydration. Often it's preceded by increased nausea, so then they smoke more marijuana because of their nausea, which just is throwing fuel on the fire, and so they have increased cannabis use. And then generally, the big thing they will all say is hot showers. And if they come to the hospital, they're like 16 hours in the shower. That's sort of the big red flag that that's what we're dealing with. And it's actually easily treated with capsaicin, Haldol, and benzos. So we usually do about a 14 to 21 day taper of some benzos, and they tend to get better. Or steroids. Sometimes steroids can work too. So what do we know, and where are we getting our information about marijuana in pregnancy? We're not doing randomized controlled trials. They're not going to say, hey, you guys like smoke a bunch of pot and you don't. Let's see what happens to your kids. But where we get most of our information are from 3 prospective longitudinal studies, so we're following babies from a birth order, or 4 retrospective cohort studies. Neither are great because we're not controlling for a lot of things, and the retrospective ones are like, hey, do you remember how much you smoked like 3 months ago? People are gonna not remember stuff, so They're pretty big studies, and the ones from the prospective groups are starting in 1978, and then up to 2001, and then the retrospective ones were all between 2005 and 2017. But one big thing to note about this is the strength of marijuana has quadrupled since the 80s. So is this information even relevant now? Can we use that information to the kids that are being born today? I mean, we don't know. That's the big thing, right? So going sciencey, and this is something like I didn't know much about at all because a lot of this information is new since I went to med school. So the endocannabinoid system, it's a system that's in all of us, whether you smoke marijuana or not. Everybody has this. It's our system designed to help our body respond to its environment, and it helps us maintain homeostasis. Homeostasis is our stability in neutral. So if I get too hot, my body will cool me down to homeostasis. If I get too cold, it'll warm me up to homeostasis. And so this can be stimulatory or inhibitory depending on how it works. And so just as an example, you get bit by a dog, you have fear, and these molecules will release, and it'll kind of release endorphins that'll kind of bring your fear down a little bit. You get anxiety and panic, and these molecules will release, and it'll kind of bring your anxiety down a bit. You get pain, the molecules will release, and it'll take care of some of your pain. And trauma, so it stimulates the immune system that comes and creates all this inflammation. You get swelling and redness and white blood cells that are coming to fight inflammation. And then interestingly, half an hour, 8 hours later, it releases more things to stop the inflammation because we don't need it anymore. So it's the one that kind of keeps you in balance. So it's involved in memory, pain modulation, sleep, temperature, appetite, emotional processing, reproduction, stress responses, inflammatory system, and the immune system. So it's everywhere in our bodies, and it's involved in everything. And this is where THC and CBD act. So it learns over time, interestingly. So repeated stressors elicit a decreased cortisol and increased cannabinoids every time you have them. So say each of these stressors is a baby, like not all at the same time, but like each time. So you have a baby, and the first time you have a baby, oh my gosh, it is just intense, and the baby crying is like nails on a chalkboard, and I have to stop the crying. And then the second time you have a baby, you're a little more chill about it. Your cortisol is not as high. Your endocannabinoids are. And then the third time you have a baby, you're just like, stop. Now the endocannabinoid system, again, it's all over the body. We have two different receptors, CB1 and CB2. Those aren't really that important, although just knowing that the CB1, which is where THC binds really strongly, is very, very numerous in the central nervous system. So in your brain and your spinal cord. CB2 is a lot of the other cells. There are some in the brain as well, but both of them have been found also in the uterus and in the placenta. And so it plays a role in embryo development. So literally, when you're in the blastocyst stage, we have only a few cells, it's part of that. In taking that egg and then that embryo down into the uterus, it's part of that. And then implantation, it's part of that as well. They've found CB2 receptors in miscarriages of 11 days. So we know these receptors are there at the very beginning. It's also involved in the placentation, how and where the placenta inserts and how deep. So it could increase your risk for placenta accreta, placenta previa, increase your risk for abruption and subchorionic hemorrhages, increase your risk for miscarriage because of that. So it's also suspected that there could be a role in labor and timing because, again, your body wants to get back to homeostasis where it's not pregnant anymore. So it's involved there as well. And so where does THC and stuff come in? So THC and CBD are very, very, very lipophilic, which is fat. And so it loves to go to things that are full of fat. And in a developing baby, what has the most fat? The brain. That's where it goes. So it definitely accumulates there. And so in fetal brain development, we know that's where it is. There's tons of neurotransmitters that are, or receptors involved in the neurotransmitter systems. High concentrations, especially in areas responsible for memory, emotional regulation, and cognition. So THC exposure makes the brain, they assume, and they have some small studies, making it more susceptible to damage from alcohol and other substances like tobacco. So it kind of like opens the floodgates for other things to come in and hurt baby. In organogenesis, so reading some of these studies, there was some links to differences in pancreases of kids that were born. And it was different in girls and boys, which is interesting. But so that could have metabolic implications, increase your risk for diabetes later on in life. There's reproductive effects. So they found that there's receptors in both ovaries and testes, and in kids that were exposed, they developed later, lower levels of hormones, they ended up being smaller. And so again, we have the potential to affect your kids' reproduction and fertility later on in their lives. Male fetuses seem to be more susceptible to early developmental effects, like everywhere in all of this development, and boys tend to do worse than girls, unfortunately. And these receptors, again, they're seen as early as like 11 days. So they're there at the very, very, very beginning, so often before people know they're pregnant. So phytocannabinoids, that's our CBD and THC. They bind. THC is exactly like the other receptors. And so a lot of people were like, well, this is why it's made for us. It was supposed to fit. That's why we should be smoking it. This is like chance. There are literally hundreds of thousands of different kind of cannabinoids. And so, of course, one of them is going to fit. There's not that many different shapes. So one of them fits. CBD doesn't link as well. It binds, but not as well. And so the way it works is very similarly to all the different systems in the body in that the more you release, once you get to a point where, okay, I'm pretty good, it actually starts filtering back and turning off the system that's releasing it. So if we have this outside place where all these phytocannabinoids are coming, it's telling your body, like, we don't need your cannabinoids. We got all these other ones coming in. So chronic use actually turns that system off. So when you stop smoking marijuana, you get anxious, you get in pain, you can't sleep, you can't function, you can't remember things. I can't function without it. And truly, there have been studies that have shown that people actually function better when they're chronic users. Like, they perform better in memory tests and stuff like this with chronic use. That doesn't mean we should be supporting it, but it's showing that we become so dependent, our natural systems turn off. And so that's kind of scary. Like, in the long, long term, could this turn us off to the point that we can't recover? And we don't know that yet. There's a lot of things that we know are associated with marijuana and pregnancy. The two things that are very, very, very well established are lower birth weights and then the long-term neurologic sequelae. A lot of the others have not as much evidence, but these two are very, very well established. We used to have a lot of like, well, the studies are mixed. They're becoming a lot less mixed, and we're knowing that in general, babies who are exposed to marijuana have lower birth weights. If there's just first trimester use, generally it's about 150 or more grams different than their cohorts. After the first trimester, we also get decreased head circumference. Your head circumference is proportional to the size of the brain, so obviously that's not a good thing. It's a dose-related risk, so the more you smoke, the more we're going to have these problems. And baby's birth weight is one of the best predictors for their long-term health and development. So that one's kind of scary. Long-term neurologic sequelae, we start seeing changes as early as 15 to 18 months. And so this is the thing, is their babies come out and they look normal. And they start going to the doctor 2 months, 4 months, 6 months, they do their developmental screens, and those are normal. Oh, we passed the test, we're good. A lot of these things don't show up until adulthood. So just because your baby's fasting at the beginning doesn't mean we don't have problems. But we can see increased aggression, hyperactivity and attention deficits, difficulties with verbal and visual reasoning, impulsivity, increased anxiety and depression, increased risk of substance use disorder and earlier than it would have been, poor adolescent and adult achievement, lower IQ, so lots of things. Other effects that we see, low birth weight, which is by definition less than 2,500 grams. So not all of them will be that, but some of them will. That by itself has increased risks of cognitive delays, neurodevelopment disorders like ADHD and autism, childhood obesity and hypertension, 2 times the risk of depression, 2 times the risk of social dysfunction, and then increased adult psychiatric disorders. So lower head circumference has increased risk of depression, social dysfunction, and somatic symptoms. So these are all like very long-term things that are happening. Other possible effects that we don't have as much robust evidence for, or is possibly a lot of confounding. Spontaneous abortion, congenital anomalies like anencephaly, omphalocele, disruption of brain development, placental abruption, increased risk of stillbirth, preterm delivery, abnormal Apgar scores, small for gestational age infants, increased NICU admission, prolonged arrested labor, and precipitous labor. Interestingly, these guys, there were some studies that aren't terrible, but they're not fantastic either. But they were looking at trying to separate marijuana from marijuana and tobacco, and they actually showed that it's a lot of the two of them together caused that, and they didn't find the same results when they were just looking at marijuana. Again, they're not great studies. We need a lot more research in this area, but these are possible confounders. So we can't say definitively that it's just the marijuana that's doing these things, but there's definitely a link there. It does it more with tobacco than tobacco by itself. So. Other effects in pregnancy, this one was really interesting. Evidence that it changes our epigenetic mechanism. What does that mean? So gene expression has changed without changing our genetic code. All of us have 2 genes for our eye color, one from our mom and one for our dad, and we're only expressing one of them, so your body automatically turns off the other one. So marijuana and THC, or THC and CBD rather, can go in and turn genes off that you want on. And some of the genes, or it can turn genes on that you want off. Some of the genes that it's linked to are genes with ADHD, autism, addiction, psychiatric illnesses. So it's turning these on, which is scary because we don't have any control over that. Placental effects, there's some evidence that it causes placental insufficiency. That can lead to small babies, it can lead to preeclampsia, and then a placental attachment. We know that there are some evidence that the spiral arteries that connect it to mom don't go as deep, so increased risks of abruption, increased risks of stillbirth. We also see 5 times the amount of carbon monoxide in people who smoke marijuana versus people who smoke tobacco. So babies need oxygen when they're developing, and not having oxygen is terrible for their development. So that's pregnancy. Now we're going to talk a little bit about lactation. So marijuana and lactation, this one's hard. We don't have as great the rates. They definitely seem to be higher in terms of reporting, but we're estimating about 10 to 15%. THC, again, it's fat soluble. It likes fat, and milk, human milk, is very, very, very fatty. So it goes in there very easily, and the plasma to milk ratio is 1 to 8, so there's 8 times as much. The oral bioavailability, so the amount the baby can actually get from that, is actually pretty low, thankfully. And they get about 1 to 5% of the maternal dose, average is about 2.5%. The studies are really, they're not very good, they're not very big, and it's really hard to separate it from like, well, which is just lactation, and you definitely weren't smoking when you were pregnant, or smoking tobacco, so how much of this is just marijuana in pregnancy? Very hard to separate that one, so we need a lot more studies on that. In general, we see a lot of similar outcomes as the exposure in utero. We know in extreme cases it could cause sedation, lethargy, and poor feeding, but I kind of wonder like how much of that is the parents smoking right in front of their baby, because that would do that too. THC can stay in human milk for 6 days to 6 weeks, depending on how heavy of a user they are, and that's from the last use, so that's a lot. It's got a half-life of about 39 hours, and there is some evidence that it might decrease the milk supply because it can shut off prolactin a little bit. It also can shut off and turn down TSH, growth hormone, and then it increases your stress response hormones that get released. So it does a lot of stuff that can affect breastfeeding and your milk supply and stuff like that. So there are some short-term outcomes. This one was interesting, and I do feel like this is incredibly relevant because this is a place that I don't think we're doing our best. Now, in Fort Wayne, we're doing great because we do have a really great supply of donor milk. But so they looked at early preterm babies, so like 23 to 28 weeks. And they looked at if we give them THC positive milk versus formula or THC negative milk, what are the outcomes? Well, they were the same. They were exactly the same. And so why is that important? Well, because if we don't have donor milk, but mom is producing, they're actually better to get breast milk that has THC in it than to get formula because of all the risks that early preterm babies have of necrotizing enterocolitis and all these other infections. And so the benefits of breast milk in this population is definitely higher than the risks of marijuana. So there was a study, it's not very good, and it was one, but it was cited literally everywhere. And that's the only reason I wanted to talk about it. It was talking about it like it might impair motor development at 12 months. It was literally one study, and everywhere else the motor development was fine. So, and it wasn't a large study. It also decreases IgA in the milk of THC users. IgA is an immunoglobulin that moms give their babies, and it helps protect them from infections. So it decreases or increases their risk of infections, decreases their protection. And it may or may not impair a parent's ability to care for their baby. I had a mom who, no red flags at all. Her pregnancy was great, prenatal care was wonderful, she came to every appointment, I never smelled anything on her, her responses to everything were right. Baby came in for 2-month appointment, everything was great. Came in for the 4-month appointment, everything was great. And then I didn't see baby again until I think she was like 10 months, and she had regressed past like 4 months. She wasn't sitting up, she wasn't rolling over, she couldn't crawl, she couldn't even like lift her head off of the floor. And her parents had her laying in the bed, and they would blow marijuana smoke on her so that they could just sleep all day. And this poor kid, she was removed. And she's doing great now, but not just inhibiting their ability to care for their baby because they're sleeping, but it impairs their judgment. That's a terrible decision to do that. So. Dr. Thomas Hale, I don't know if you've heard of him. So this guy is a professor in pediatrics and an associate dean of research at the Texas Tech University. He's like the guy in breastfeeding and pregnancy medications. He's the executive director at the Infant Risk Center, which if you don't know about this, it's an awesome resource. They have a 24-hour number and an app where you can look up any med, any CT contrast study, anything, and it'll tell you about the safety in pregnancy and lactation. He is the foremost expert in perinatal pharmacology and the use of medications in pregnancy and lactation. He has this book, Hale's Medication in Mother's Milk. And so his statement was, in low and moderate use, the levels that pass in a milk are exceedingly low. The rest of the story is when you take marijuana orally as a baby would in breast milk, only 1 to 5% is absorbed, 99% is picked up by the liver, and it never gets to the plasma. What is real is that even if the baby nurses right after the parent smokes marijuana, the baby will get at very most 8.7% of the parent's dose, and they will only absorb 1% of that. So basically the point of that is babies are not going to get high from the milk, but we don't know how much that little bit can actually still do stuff in the background. And chances are it's still doing stuff. But in terms of should people breastfeed or not breastfeed, that's where this stuff sort of comes in. And he spent years researching that particular part. So when we're looking at all the groups that make statements, all of them kind of say don't. American Academy of Pediatrics, one of the big things about their statement that was used terribly was they said, street drugs such as PCP, cocaine, and cannabis can be detected in human milk, and their use by breastfeeding parents is of concern, particularly regarding the infant's long-term neurobehavioral development, and thus are contraindicated. That does not mean if they're smoking marijuana, they cannot breastfeed. It doesn't mean breastfeeding is contraindicated. It means that smoking and marijuana is contraindicated, i.e. we cannot support it, but it doesn't mean that we should. And they actually put out a second statement that said maternal substances use is not a categorical contraindication to breastfeeding. So it does not mean they can't. ACOG, there's insufficient data, so we can't say it's safe. Academy of Breastfeeding Medicine, same thing. But it may be legal. Everyone, again, we get to this issue of legality, but there's a lot of things that are legal that aren't good for us. Just because they're legal doesn't mean they're good for us, and they're definitely not good for your baby. And then we talk about secondhand marijuana smoke. So even if you're not breastfeeding, if you're giving your baby formula, you can still have this risk of secondhand smoke. Marijuana smoke has the same chemicals as tobacco smoke, including all the ones that are linked to cancers. So it can impair blood vessel function, and longer than tobacco smoke, actually, which is interesting. And so there's possible risks for cardiovascular disease just from being exposed. We also have second and third hand smoke. Third hand smoke is the smoke on your clothes, on your couch, in your hair, on your hands. It increases their risk for asthma. That one's very sort of well known. And then we have this potential risk for SIDS, which interestingly was higher when dad was the smoker, which I thought was interesting. So. Can kids get high from secondhand smoke? Absolutely, they absolutely can. And their brains are still developing until they're about 25 years old, so this is terrible for a developing brain. And then the other thing to note is marijuana smoke versus, ingesting it. There's pesticides, herbicides, fertilizers that are involved in this, so that can be terrible for kids. And it may have permanent effects on their executive functioning, their memory, and their IQ. So I always kind of tell patients, you wouldn't give your kid a joint, but smoking around them that's literally what you're doing. And I'm not trying to make you feel bad, but I don't think you understand what you're doing. You're hotboxing your kid. So how do we start this conversation? As she said, this is a difficult conversation, and she's right. We do not do this well. We don't, because there are times when, so I actually had this, literally this is why I was late running in here. I had a patient who came in, and I walked in the room, and I could smell it, and I was like, well, isn't this ironic? And I was about to sit down and talk to her, and I was like, so how are things going? And she was like, terrible. I'm so depressed. I was like, okay, so we talked about it for a minute, and I'm like, are you seeing anybody? Do you want a referral? Do you want meds? What? Tell me more about this. And I was like, have you thought about hurting yourself? And she's like, not really. Oh, okay. So she'd been thinking about it might be better for everybody else if she wasn't here, which is one of the most severe forms. This is definitely not the time. As much as smoking marijuana is not good for her right now, the last thing I'm going to try and do is pile on some guilt. So this was not the time for me to talk to her about it. But this is the sort of situations we get. What if the next time she comes in, she's bleeding? And so we get these situations where it is really hard to have these conversations. The stigmatization of substance use in pregnancy and lactation, too, has been very linked to punitive approaches that disproportionately affect minority and poorer populations, especially young, poor Black women. So it's something that we have to stop trying to be punitive about it and be educated. We should educate them on why it's good not to do it rather than tell them all the terrible things. Talk about the risks of discontinuing, or If we are punitive about things, then we risk them discontinuing their prenatal, postpartum, or pediatric care. If you're not nice to them, and I can tell you, they come to me a lot of the time when someone hasn't been nice to them, and they never want to go back. They will never go back to a certain hospital or a certain doctor or whatever. So these from the California Preterm Birth Initiative, these are 3 women just talking about, you know, of course, I could talk to them, but I'm worried about what they're going to do about it. I'm worried that they're going to call CPS on me. I'm worried that they're going to judge me. And I mean, I don't really need to tell them. It's not that important. So in medicine, we have 4 principles of medical ethics. Our first one is beneficence, doing and promoting good, preventing and removing evil or harm. So how do we do it in this situation? We can discuss the benefits and recommended cannabis-based medicinal products when it's indicated, and then talk about, like, look, you have nausea and vomiting. We have studies that show this is not good for nausea and vomiting, and this isn't great for your baby, so let's see if we can find something that's better for you. I'm going to help you. We're going to do some good. Non-malfeasance, do no harm. We're avoiding harming the patient. So discuss the short and long-term risks to mom and baby. We want you to stop. We want you and your baby to be healthy. But we don't want to scare them away, because scaring them away is doing harm. They're now not getting prenatal care. They're going to show up at the hospital, who knows when. Their labs aren't done, all this stuff. Respect for autonomy. Respect for the individual patient, his or her ability to make rational decisions and moral choices. This one's tricky when we are talking about babies. So we want to assess if the patient has capacity, obtain informed consent for procedures, including drug screens. It is illegal to get a drug screen without their consent in Indiana. Demonstrate weighing of costs and benefits in collaboration with the patient and the patient-centered decision-making. In the world of pediatrics, they have the right to refuse things, like vaccines. Like, that's a big one, right? And so if it's not doing harm to their baby, they have the right to continue doing those things. And we can't prove harm in lactation. So unless they're neglecting their baby or we're seeing things that are showing signs, we don't know that they're hurting their baby. So the best thing we can do is educate them to stop. Justice, we want to treat them fairly, equitably, and appropriately. Ensure that they have adequate access to treatment and care regardless of the decision. One of the big ones here is if they are smoking marijuana and they want to breastfeed, we don't restrict their ability to go to a lactation consultant or a breastfeeding group. We educate them just like everybody else, but we counsel them on the risks. How do we continue the conversation? A great quote I saw is, clinicians should ensure that people who use cannabis in pregnancy are treated in a neutral, non-stigmatizing way and are supported to make healthcare decisions based on evidence rather than ideology. So I wouldn't, smoking marijuana when you're pregnant is bad for your baby. It causes growth restriction, preterm birth, it could even kill your baby. It's selfish that you keep smoking and you just need to grow up and stop. That's what you need to do. And I've had patients that are told pretty much this exactly. The way I like to approach it is, look, I understand that it's hard for you to quit, and I know that you would never want to hurt your baby. I know that you wouldn't want to, and I learned so much from doing this. I'm sure they don't know all the risks involved. So there's some very real risks for your baby, and I know you love them, so let's see if we can find a way to cut down and help both of you be healthy. You want to be positive about things. How do we intervene prenatally? We want to screen every single patient with a validated screening tool like 5Ps, the NMSS, the NIDA screen, which will be discussed in a bit. Universal urine screening is not the answer. Universal urine screening doesn't pick up the one biggest thing that we're seeing a lot of growing right now is fentanyl. It doesn't pick that up. It's not the way to do it. And it often can lead to problems if you're not getting consent. So, educate them, assess their motivation to change. Do you want to quit? Do you understand what the risks are? If I tell you the risk to your baby, is this something you want to do? Can we find a way to do this together? Discuss the risk-benefit ratio of cannabis use. Talk to them about how to prevent unplanned pregnancies if they're not pregnant yet. Are you tracking your period? Can I give you fertility awareness? How do you track your period? How do you know when you're ovulating? How do you know when you're going to get pregnant? Talking to them about contraception if that's something they want. And then doing pre-contraception education. Improving their diet and lifestyle. So if you're improving their diet and lifestyle, they'll be healthier. They might feel better. They might not be in pain. They might not feel the need to use marijuana for sleep or pain or these other things. Identify and refer and treat for substance use disorder, mental illness, especially in your vulnerable and high-risk population. And identify and address social problems. And that's all about the social determinants of health. Public health interventions to educate the general childbearing population on the risks, because again, I feel like a lot of the information is not out there. Prenatally, or antenatally rather, so now they're pregnant, know who has factors that are going to be the risk factors for ongoing use. Note if they're not smoking it, so they're not going to smell like it, but they're ingesting it. offer multiple drug screens, and discuss these aren't to punish you. I'm not trying to catch anything. I want to identify who's at risk. And if you are in recovery, I want to start building evidence to show that you're in recovery so that if you ever need to, you have this. So it's for them. Monitor for cannabis withdrawal syndrome. It's got a lot of different symptoms where they're irritable, they're angry, nauseous, fever, chills, headaches. And then develop integrative care clinics where they can get their prenatal care, pediatric care, primary care, counseling, psych care, parenting and social support, and substance use treatment all in one place. I can do that. I can do some of that. I can't do all of that. And then use evidence-based treatments such as motivational enhanced therapy, aka motivational interviewing, and cognitive behavioral therapy. Postnatally, your feelings about their situation should not dictate the rules. So they did a survey, this actually came out in January, of 69 newborn nurseries, and 96% of the nursery directors reported that marijuana use, and sorry, that shouldn't say pregnancy, it should say lactation. So marijuana use and lactation was somewhat or very harmful. We don't know that, so we can't make those statements, but they found that mothers who tested positive for marijuana use were restricted from breastfeeding in 16% of these hospitals. And they would use language in the charts like, caught them breastfeeding again. Multidisciplinary approach between the PCP, obstetrician, pediatrician, social worker. Consider referrals if appropriate. And then monitor the babies for withdrawal symptoms if appropriate. Counsel them on abstinence while breastfeeding and chest feeding, and then following that baby closely to make sure you're monitoring for development, and then you can refer. Medicinal marijuana, there's no known safe amount, but could there be situations where someone needs to use it? Maybe. There might be. It all has the same effects, except there may be less pesticides, herbicides, fertilizers that are used because it's more controlled. Ideally, you want to find an alternate therapy. Will it work as well? Maybe. Is it good enough? Maybe. These are all the things we use medicinal marijuana for. These are the 4 big ones. I'm going to block out the ones where you're going to get later in life. They're probably not fertile anymore. I'm going to block out the ones that are having so many issues, I doubt they're also getting periods. I'm going to block out these ones because if they are so severe with these things that they need medicinal marijuana, they're probably also not healthy enough to get pregnant. So we're not left with a huge group of things. Irritable bowel, dystonia, PTSD, MS, epilepsy, glaucoma, and Crohn's. There are definitely multiple therapies for that, but this isn't a large group of women that need to continue using. And then nausea and vomiting, we know that's not true. So what are our recommendations? Before and in early pregnancy, patients should be screened. And then patients who report marijuana use should be counseled on the risks. Ideally, people are quitting long before they get pregnant because, again, it's lipophilic, it lives in your fat, so you can keep releasing this for months depending on how heavy a user you are. Patients who are contemplating pregnancy should be advised to stop, and people who are using it should be counseled on finding alternative treatments if they're trying to get pregnant. We know the adverse effects of direct marijuana use on neurodevelopment in children and adolescents. And longer-term effects from marijuana exposure in human milk are just really not well studied. And the benefits of human milk and breastfeeding are very, very well studied, and we know that there's tons of great stuff. Decreased in SIDS, decreased NEC, decreased hospitalization rates for diarrhea and respiratory illness, decreased postpartum depression, decreased chronic illnesses later in life. So the benefits of breastfeeding in general generally outweigh the risks of marijuana. General. If they're going to do it anyways, and you tried your best, and they're going to do it, just try and get them to cut down and minimize use. Counsel them regularly, often frequent help with quitting. Smoke outside, away from windows, doors, and vents. Do not smoke anywhere near your children, in your car. Teach children to stay away from secondhand smoke, and be mindful for them to prevent third-hand smoke. Washing their hands, changing their clothes, wear a hat. And then be honest with kids about the difficulties in quitting and encouraging them not to start. And then things to consider for future studies, looking at this increased concentration. We need new cohorts, huge ones. Use of pesticides, herbicides, fertilizers. Again, the CBD is regulated by the FDA, but marijuana is not. Investigating CBD. There's no studies looking at CBD in pregnancy and lactation. And then looking at marijuana smoking versus vaping, sublingual use, ingestion. And then effect of the partner's cannabis use. These are some great resources. On either side, we have handouts from ACOG that are available for free on the internet. And then Infant Risk is a phenomenal resource. They have a 24-hour line where Thomas Hale will answer the phone himself sometimes. And you can be like, what about this med? And they'll literally tell you if it's safe or not. But their app is great. And there's lots of references. And those are my 4 children. Questions? We don't know. And that's where the paternal use, we don't know about that. So, but it could. We know that it does stuff. We know that there's receptors down there. We know it turn genes on and off. So I would assume until it's proven otherwise that it's not good. But we don't know.
Yeah, I had a client just last night that had been smoking marijuana the normal way, and she said since she found out she was pregnant, she was really struggling with her nausea, and she vaped it instead, and then she had some edibles. What's the difference between those in terms of the amount that they're getting if they're vaping it?
It depends on what they're vaping or eating, because if it's like CBD and it has the Delta 8, Delta 9 stuff in it, which is legal in Indiana, or if they've gone to a dispensary somewhere and gotten that, it depends on their physiology. I would assume if you're feeling it, it's there. You're at risk, and most of them are going to do enough to feel it. So that one's a hard one. That's where we don't have enough information about that. But again, it would probably do the same thing.
Thank you.
Thank you
very much. I learned so much.
Okay, so like she said, my name is Erica Deathe. I'm a licensed master level social worker, and I work as a certified recovery addictions coach. I've been working with women with substance use disorder in some capacity for over 5 years. Like I explained, I had 2 different roles. I've learned a lot about the vulnerability of those who use substances, as well as them being a mother. I am a mother myself, and I also have family members who struggle with substance use that are very close to me. It's an interesting thing to have the professional knowledge to work with clients, but also to have some insight into the lives of those who use substances and what it does to those around them. Okay, so in my current role, like I said, I've been a maternal recovery specialist for over 2 years. We work with them who are pregnant and also through that first year postpartum who have substance use diagnosis. I walk alongside them as a peer recovery coach and support them in any and every way they desire. Being a peer recovery coach means that I'm a partner to them on their recovery journey, no matter where they're at on that spectrum. Their recovery journey is often multi-layered and often very complicated, especially once a pregnancy is added to the equation. Although there is often a new source of hope that arises once a baby is involved. Referrals to our program, like I mentioned, women come to us, they must either be pregnant or within the first year postpartum. They may be struggling with addiction, or they may already be in recovery, and we will still work with them. This could look like someone coming into the ER because they're ready to detox. Maybe she just found out she's pregnant, or this could be someone showing up in labor and ready to deliver, maybe had no prenatal care, but now she wants help. These individuals can be using any substance or substances. That does include marijuana, but also opiates, stimulants, or if they're in recovery, they may already be on MAP, medication-assisted treatment. They can be referred by any provider, any community program member, etc., even outside of Parkview, and then they do not currently have to be a patient at Parkview either. They could be getting their health care from another agency. Our services are voluntary and free. We work with them based on the peer recovery coach model, and therefore we assist them as much or as little as they desire based on where they are at. Of course, we hope that our clients are interested in furthering their recovery process and that they want treatment, but we will work with them regardless of what they choose, even if they have a relapse along the way. People do recover and change is possible, so there is a lot of hope. I think it's important really quick just to understand what the role of a peer recovery coach is. As a peer recovery coach, I'm trained as an ally to guide others through their own recovery process. According to SAMHSA, they define recovery as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. In other words, people are in recovery if and when they say they are. This can pose some challenges for most people, but as a peer recovery coach, the mindset is shifted to the person in recovery and what they desire, not what I think or know is best for them. So we do respect their wishes, their goals, their desires, and we're just here to work with them. Recovery should be self-directed, strengths-based, a source of empowerment. It should be based on their desires and wants. We focus a lot on their strengths. You can do it, many do. As far as communication goes, active listening is one of the most important skills. Silence can be tough, but there's a lot that you can gain from that if you're able to sit in it with that client. Interestingly enough, listen and silent have the same letters. Also using a lot of motivational interviewing, make sure you're asking good questions, providing connection, paying attention to what has heart and what has meaning for that client. Like it has been mentioned before, it's really hard to have these conversations. As social workers, we've had that education and learned those skills to have some of these tough conversations. It gets easier with time, and you learn a lot more confidence as you keep doing it. Of course, stigma, there's a lot of stigma associated with this population. Using appropriate language to empower and motivate them. So we wouldn't call somebody an addict, but we would say a person with a substance use disorder. There are 5 stages of change. It's important to understand that those working through recovery will go through a process that is cyclical and not linear. So they will move back and forth between those stages. And so that is to be expected, that you're going to have changes in those emotions, and that's where relapse falls into that also. Recovery pathways, what may work for some may not work for others. We provide unbiased guidance. Again, very individualized to that person. Recovery wellness plan, this creates a framework for the recovery to ensure that they're meeting their goals. So it includes all of their connections. So this could be with their recovery community, physical, emotional, spiritual health, their living situation, their job, etc. It's important for them to be aware and create goals in all of those areas of their life because they all affect each other. As far as services with maternal recovery, like I mentioned, we do work in an outpatient setting. The communication that we provide to them is whatever they prefer. So some may prefer texting, because that can be easier when you have kids or have a baby. And well, with being outpatient, we can meet them wherever they're at. So a lot of times we try to catch them whenever they're within our network, because we do have access to see, when they may have an OB appointment, if they come into the ER, when they come in to deliver, things like that. We'll bring them information, bring them resources, and then sometimes it's just being a support for them. So sometimes this looks like meeting them at maternal fetal medicine for an appointment. I had a client who had no support with her, and so she invited me to come into the ultrasound with her and hold her phone over FaceTime for her sister because she couldn't be there. Oftentimes our patients who struggle with substance use disorder lack that support network because most people in their lives have written them off. They've burned those bridges, most likely due to the negative choices that they've made. Collaborating with other community programs, so we can send referrals or just provide the information to them. A lot of pregnancy organizations like you guys all here, and help them prepare for baby. We also can help advocate for them and work with them. So caseworkers for DCS, actually was in the parking lot before I came in talking to one of the FCMs about the involvement my client has with our program and how that can help her in her case. Of course with their consent. And then, so sometimes a lot of times where that becomes really helpful is we have a mom that will come in and she'll start MAT, which means she's stopped using her substances. Maybe she's taking a medication to help her with that. Maybe she's not. But we can sort of validate her engagement level in all of her appointments. If she is doing MAT, how compliant she's been going to those appointments and getting her prescriptions, and that does help her, as I'm sure you know. As far as the healthcare team, when they do come into the system, whether it's to deliver, if they're coming in to detox off their medications or looking for treatment, we help work with the care team for that. So sometimes this could look like, for example, reaching out to the head of the anesthesia department to discuss a pain control plan for a patient who might be in recovery from opiate use disorder and wants an epidural, but she really would prefer to not be exposed to fentanyl. There are options out there. So we help our clients advocate for their rights and make their voices heard. I've also helped a laboring mom advocate to her healthcare team when she needed another bolus of medication in her epidural because she was in pain and it wasn't working. She feared that if she spoke up, the staff would assume she was drug seeking. If she said, it wasn't helping enough and she needed more. So we always hope to share treatment options with them, which could be, the MAP medication, getting into IOP, an inpatient rehab program, doing outpatient counseling, support groups, community programs, harm reduction. We also assist with that. So like Dr. Turner had mentioned, maybe we can't get them to a point where they're going to stop their use today. But what can we do to help them, wean down off of their use? As far as marijuana use, in our program, the highest volume of our patients are those that use marijuana. Some solely use THC, but some may also use other substances. There's a lot of controversy over THC. Unlike the other substances, what we see is mostly that this stems from the legalization in surrounding states. Indiana, however, is still illegal. As far as CBD, we see a lot of that as well. And the issue that we've seen with CBD is that it still can often contain trace amounts of THC, and clients seem to be really surprised and often very upset if they do then test positive for THC because they're using something consistently or they're using a high amount of it. They were led to believe that that product was legal and that it did not contain any THC. Many clients say they're using THC to help with an ailment. That was kind of already covered. The different forms, so vaping, smoking, edibles. The severity of their use is often very downplayed as they know using harder substances would be much worse. Heroin, cocaine, opiates. THC use has gotten more dangerous over the years due to the potency. So you can get very high potency items from dispensaries, but also the street THC that you're finding is different from than what Dr. Turner mentioned in the 80s. It's just not the same. And then also it's being found laced with fentanyl, and that is locally as well. The conversations we often have with our THC clients include encouraging them to talk to their OB to find a medication that would help with that ailment, treating the underlying mental health concern, what their supports are, lack of supports, and then what that process looks like potentially with DCS. Most of our THC clients are very open and upfront with their use, while clients using other substances may be a bit more hesitant. While their use may be downplayed, it doesn't go without mentioning that these individuals are still under the influence of a substance that alters their decision making. Their newborns are still at a high risk of negative consequences because they're not always able to make appropriate caregiving choices. So we would always encourage them to have a safe and sober support person available to care for that newborn if they're not able to stop using. What we've learned, as far as the stigma goes, there's so many negative stereotypes and bias. We do know that language matters. Most of the women that I work with are ashamed and embarrassed of their use, and therefore they do not want to seek medical care. Or if they do, they don't disclose their use. They don't feel comfortable opening up and sharing their reality. But do you know how many women I work with that are pregnant or newly postpartum who have not been told congratulations on their new baby? Most of them never hear that word the entire time they're pregnant. Yes, their situation may be very far from normal, but they may still really be excited to be a mom. We should reduce the stigma they face by treating them with that dignity and respect that they still deserve. One way is using the person first language. This allows them to be a person that has a problem instead of them being a problem. Some examples would be, like I mentioned before, call your client a person with a marijuana use disorder instead of a pothead or a druggie. A baby born to a mother who used drugs while pregnant instead of an addicted baby. Babies are not born with addiction, that is a behavioral disorder. Rather, they are manifesting withdrawal symptoms. This reduces negative associations and individual blame. rapport and trust. When I'm working with a client, my first goal is to build that rapport with them as soon as possible. If they can feel that sense of trust and know that I'm completely invested in them, they are more willing to open up and be honest about their entire situation. I ask those open-ended questions. I provide support in a way that makes them feel comfortable enough to share. I want them to know that I will stick around and be a support to them no matter what they tell me. These clients are used to most people shunning them and being shocked with what they share and then essentially, running away or not wanting to work with them. How many providers do you know that do not ask a client about substance use or mental health because they're afraid of what they may hear? A lot. Every day this happens. We have to get to a place of being comfortable asking those questions and also hearing the answers because we care, because we want to help them, we want them to get better. Think about, how would you want your family member treated? Treating your substance use disorder client in the same way. Reach out for help with other providers if you don't know what the answers are and you do need help. Overall, our moms want to be treated just like the next pregnant woman who walks through the door. They want to be met with understanding, grace, and acceptance, and they do want your support.
Thank you. There are some flyers, if you didn't hear her say that, up here. And yeah, come on up. Thank you all for hanging in there with us. I apologize that there's so much good information and so much to share. It's taking a little more time, but I was going to say you saved the best for last, but every bit has been so wonderful.
Good. Yeah.
But I know that Nicole's presentation is wonderful as well. Nicole is the CEO of McMillen Center, and I'm going to let you take it over.
All right, so Meg had asked me, how long have you worked with prenatal population? We started the Healthy Tomorrow app in around 17, 18, but someone mentioned car seats. I was a car seat safety technician in grad school. I went through the 40-hour training and provided education for prenatal and postnatal women on car seat safety. That was an interesting time doing all of that. And when you mentioned that, I was like, oh, I completely forgot about that. All right, who has heard of McMillen Health before? Raise your hand. Okay, so I don't need to explain what we are and what we do. Perfect. All right, this is a picture of our Mom and Me Days. Who has heard of our Mom and Me Days? Yes, some, not as many. Okay, I will explain what that is when we get to the app. So we are a preventive health education center. Traditionally, we have worked with children over the last 43 years. About in 2017, 2018, about 7 years ago, we started looking at and asking questions about prenatal health, prenatal concerns. We were meeting with Dr. Tony Giaquinta on a completely different project, and he said, yeah. What do you have for moms with opioid use disorder and their babies born with neonatal abstinence? And we were like, we have nothing, Tony. And he's like, great. What can you develop like yesterday for us? And we're like, on it. So we applied to the St. Joseph Community Health Foundation to conduct a study and interview moms with opioid use disorder and their babies being born with neonatal abstinence syndrome. We also interviewed some of the professionals working with them, and some of you are in this room who were part of those that were interviewed. From that, we put together a report called In Her Words. It's on our website, but the findings from that report were that women desired low literacy health education in video format that they could easily access from their phone. Professionals wanted training, resources to give their staff to be able to serve these women, and resources to give the patients and clients that they were serving. So, like I mentioned, that report is online. We determined from there video content, low literacy, accessible from your phone. We need an app. So we launched the Healthy Tomorrow app in 2020. Today it has it has 562 users across 151 zip codes, 86 low literacy videos, and those videos have been, 36 of the videos have been translated to Arabic, Burmese, Dari, Farsi, and Spanish. Zooming through, we want to thank our funders for making this possible. This has been a huge labor of love for us. It started with the St. Joseph Community Health Foundation investing in this project. Over the years, it has expanded. We would not be able to do what we have done without everyone in this room. You all have contributed knowledge, information. We are not subject matter experts on the content that is within this app, but you are. And we've brought you to the table, we've brought your patients, your clients to the table to review this information, so it wouldn't be possible without all of you as well. So thank you. All right, so motivational interviewing. Who's heard of this? Some of you, all of you, for the most part. All right, a little bit about motivational interviewing. What I've heard from Dr. Turner, from Erica, is listening. Who's a great listener? Only some of you? I kind of fall into that boat too, I can feel that. All right, so it's a style of communication that requires really good listening. It requires information and advice after listening. So that listening part is really important. And you also need to summarize what your patient or client says to you, so that way that you can reiterate to them, like, hey, I've paid attention, I hear what you're saying, and I want to help you. Motivational interviewing is also designed to empower people to change by drawing out their own meaning, importance, and capacity to change. So that means you're helping them come to a conclusion. You're not telling them what they need to do. And then it's based on respect, a curious way of being with people that facilitates that natural process of change. Again, you're getting their buy-in by helping them come to the conclusion that is most desirable. So motivational interviewing and caring for moms using marijuana. We've already heard today that you are going to hear that marijuana is safe. It is natural. It helps with my mental health. All of those things we've kind of talked about already, and Erica did mention open-ended questions. So when we're starting to have those discussions about marijuana usage, no, it's not going to be easy. But we don't just want to say, do you use marijuana? Yes. Okay, great. We're going to move on. Do you use tobacco? Yep. No, we want to stop. We want to have a question, and we can say, okay, you have shared that you are using marijuana, and sometimes they will, sometimes they won't. Eventually it may come out some way, somewhere. We have resources within Healthy Tomorrow, videos for the clients and patients, but also within the professional guide, we have resources to help you have these discussions. Yes, they are difficult, but we have motivational interviewing prompts for you to start that dialogue. So that way if your client or patient does indicate that they are using marijuana, we have those questions for you. So for example, if they indicate yes, okay, well on a scale of 1 to 10, could you share with me where you would fall on that, on wanting to stop using marijuana? 1 is, yeah, no, not at all, or 10, I really think I want to stop. I think it would be good for me and my baby. So say they pick 8. Okay, why would you pick number 8? And then you start to have a discussion. Okay, well, why would you pick number 8 because you think it's healthy for your baby? Let's talk about why it would be healthier for your baby. So then you can provide that information, and they're contributing to the conversation. It's not just, you should stop using marijuana and move on to the next thing. You have to get their buy-in. You have to get them to understand and be part of that conversation, so that way they want to be part of the solution, and you're not just telling them what the solution is. So make it their decision. Healthy Tomorrow resources. So these are aimed at the professionals, so that's all of you in this room, serving your clients. There are tips for medical and non-medical professionals. So most of our professional advisory group members were from the medical field. However, some of them were also from home visiting organizations. Healthier Moms and Babies has been instrumental in us creating this app, as well as their clients piloting it with us, and then we get lots of referrals from you guys as well. So we appreciate that. But and Healthier Moms and Babies does have medical professionals. I didn't mean to indicate that you're not, but this could literally be used by any organization. We have organizations at Bright Point, for example. They're home visitors. They may have medical knowledge, but they're not all medical providers. So this could literally be used by any professional serving prenatal, postnatal women. Each topic includes related app videos. So within that guide, it's going to say, okay, for this section, link women to these videos on the app, motivational interviewing prompts, and then there's always a handout and action plan that correlates with that. All of these resources are completely free of charge on our website. There's going to be a QR code that links you to that guide right on our site. So within the guide, there's 63 digital handouts, 2 that are specific to marijuana usage. Again, those handouts link to videos, and they're available in English and Spanish. If you have a need for another language, just reach out to us and ask us if it is available in that language. We are always looking for ways that we can reach more individuals. If it's in a different language, we're happy to see what we can do to make that happen. Okay, so here are the tips. This kind of breaks down what the professional guide looks like. What you need to know section. This is going to be an overview for the person using the guide to give them a background on safe sleep and baby birthing. Next is going to be the getting started. Here are the videos that you can link your client to. And then deeper dive is where the motivational interviewing is and those affirmations. So you always want to affirm, encourage them to keep sharing, and never open-ended questions on the left side. So the deeper dive. Next step, so those are the handouts, linking. So these handouts, everything here is digital. You can print the handouts out, you can link them to your client, you can email them, you can text message them. Any of this format, it's all digital, it's all free. Next steps, and then there's action plans. So I know that there were quite a few individuals here from DCS. We have a whole section about working with your client and DCS and them coming up with a plan so that way they can show DCS like, hey, I have a plan if, you know, I have a next of kin already identified. I have who you should contact, who I'm working with for my MAP. We also have a letter in there for your MAP provider to be able to sign. The template is already there to show DCS that you are working with them and they're actively trying to improve. Another action plan, this is the QR code to the professional guide. If you don't have it, you can scan and it will take you directly there. Accessing it, again, it's free on our website. We also have received funding to redevelop Baby and Me Tobacco Free. So that has been fully developed. We are starting to offer training. So we have this curriculum. It's 9 modules called Fresh Air for Baby and Me. And we are piloting this, so it's completely free, for 75 Allen County women. So if you have clients or patients or anyone that you would like to provide education on smoking cessation, so this includes tobacco usage, marijuana usage, and vaping. This is a comprehensive 10-module session. Interactive, there are 45-minute sessions. McMillen is providing these free of charge, and then the participants are going to receive diapers, wipes, and they're entered to win a $250 Visa gift card as well. But the curriculum includes 10 modules, 9 low literacy videos, bilingual handouts, take-home activities, and then they'll also receive a participant journal. I plugged this in here so that way you knew that this also includes marijuana. And then this specifically are the dates that we are providing it and the enrollment now. If you would like more information, I am happy to get with you after this and take your information and send you the link and registration. Any questions? I fire hosed you, I feel like. I feel like most of you are probably familiar with Healthy Tomorrow. Many of you in here have participated in some way, shape, or form on the professional advisory group, so thank you for your knowledge.
Your contact information emails are on the agenda for everybody, so you can follow up. I think we gave Dr. Turner a pass on that one. So, other than that, if you can take a moment, or if you haven't already, fill out the evaluation that tells us in our advisory group what you want to hear, other topics as we're planning these out. We really do pay attention to that. One last quick most plug too, we have these directories, if you want them, they're on our line. They're free to give to clients or any of their support team. Resources, pretty much everybody who introduced themselves in the room are probably in here. And we'll be doing a new one this year and be seeking input. But thank you all. Thank you so much for our speakers. Wow, a lot of great information. And thank you to everybody on the advisory committee. And I didn't introduce them. I should ask them to stand up very quickly, so they're the ones who helped design the program. So if you're on the advisory group, please stand up really quickly. You guys know the work. Thank you. We are grateful to them because they are really the subject matter experts who help us put together these programs. Thank you. Have a great afternoon.